He graduated from Nippon Medical School and trained in the Department of Anesthesiology at the university's affiliated hospital and in the pain clinic department of Kanto Teshin Hospital, now NTT Medical Center, Tokyo. He became the director of Kamakura Genki Clinic, and in pursuit of a holistic approach to medicine, he has deepened his expertise in Oriental medicine, psychiatry, balneology, orthomolecular medicine, and complementary and alternative medicine. At Kamakura Genki Clinic, he provides comprehensive care with a strong focus on mind-body interactions, while also serving as an occupational physician dedicated to stress management and preventive medicine. His primary research interests include ozone therapy, high-dose intravenous vitamin C therapy, and clinical applications of antioxidants. Please, a warm welcome to Dr. Hiromichi Matsumura.
Thank you for the kind introduction. And first, let me thank Dr. Homer, Lim, and all of you for inviting me to speak at this wonderful conference. Today, I'd like to revisit glutathione, not just a master antioxidant, but a molecule with broader roles. In this talk, we'll cover 8 axes. Before we take them one by one, let's look at how GSH is made and the structural features that make it work. GSH is made in 2 ATP-dependent steps. The first, rate-limiting step, ligases glutamate and cysteine. The second, adds glycine. Because the first step is cysteine limited, supply is key. It comes from diet and cellular uptake, and briefly, the so-called methylation cycle. Functionally, GPX uses GSH and forms GSSG. GR reduces GSSG back to GSH using NADPH. And 2 structural features matter. First, the cysteine file, the SH group. Here. The laser point doesn't work well in this situation. And it's the reactive center that drives most of glutathione's actions. Second, GSH has a gamma-glutamyl bond, not the usual alpha-peptide link. This bond stabilizes GSH and allows it to act as a major intracellular thiol buffer. With that structure in mind, let's start with antioxidant actions. Antioxidant actions of glutathione, direct and indirect. Direct, GSH rapidly scavenges hydroxyl radicals. Indirect, GSH is the essential substrate for GPX, which reduces H2O2 to water. With the hydroxyl radical in mind, the first line of antioxidant defense is preventive. SOD, GPX, and catalase handle the upstream steps, the blue owl. So the formation of the hydroxyl radical is largely prevented. The second line is radical scavenging antioxidants. Several form the antioxidant network. GSH is one of these members and supports the network. Put simply, these 5 antioxidants quench reactive oxygen species, ROS, and are then regenerated by partner antioxidants in the network. Because they mutually recycle one another back to the reduced state, we call this the antioxidant network. GSH handles not only LOS, but also reactive nitrogen species, such as peroxynitrite. Moreover, its action extends beyond direct radical scavenging. High NO plus oxidant flux can generate GSNO2, a scavenging byproduct that briefly binds NO, but it isn't a regulated reservoir. By contrast, GSNO is the physiological NO reservoir. Next, let's look at GSNO. GSNO is S-nitrosoglutathione. NO bonds to GSH. From GSNO, follow the left arrow. It transfers NO to a protein file, PSH to PSNO, by S-transnitrosation. This reversible NO attachment to cysteine is called S-nitrosylation. On the right, GSNOR degrades GSNO and shrinks the reservoir, helping to turn the signal off. Targets on duration are set by the balance between GSNO formation and GSNOR clearance. There is substantial literature on GSNO's clinical relevance. Let's look at our representative paper. Why this matters clinically? GSNO is a regulated NO reservoir. This figure shows that airway GSNOR activity is increased in asthma, consistent with enhanced airway hyperreactivity. When the balance between GSNO and GSNOR is shifted low, tissues show low NO phenotypes. Endothelial dysfunction, airway hyperreactivity, and impaired microvascular perfusion. Preserving GSNO or tempering excessive GSNOR restores S-nitrosylation, improving vascular and airway tone. Treatment map, 2 tracks. First, direct approaches and investigation. Raise GSNO by inhibiting GSNOR or using inhaled GSNO. Second, the supportive track we actually use. Maintain the thiol redox base and lower oxidative and nitrative stress to protect mitochondria. Now, thiol switches. Protein S-glutathionylation is a reversible thiol switch. It places a glutathione cap on reactive cysteines, protecting them from overoxidation and modulating protein activity. In many enzymes and ion channels, adding this cap decreases activity and limits catalysis during oxidative stress. Under reducing conditions, glutaredoxin removes the glutathione cap and restores their function. This is deglutathione. Think of it as protection and signaling in one. In this figure, hypertensive rats show elevated ENOS as glutathionylation, which is reversed by the thiol-reducing agent, DTT. This modification uncouples ENOS. When uncoupled, ENOS stops producing NO and instead generates superoxide. When the glutathione cap is removed physiologically by GSH, or here with DTT, ENOS recouples, NO production is restored, and endothelium-dependent relaxation recovers. This vascular dysfunction is redox tunable. To favor D-glutathione relation, first, raise GSH. Because cysteine is rate-limiting, regimens typically begin with NAC. You can also consider GSH itself, oral, liposomal, or IV. Clinically, I also think of ozone therapy as an upstream way to support GSH production via NRF2 activation. Next, raise NADPH. Support the pentose phosphate pathway with thiamine. Use riboflavin to drive GR and niacin to maintain the NAD and NADP pool. Ensure selenium for GPX activity. Then lower oxidative and nitrated pressure to maintain a reducing state, allowing PSSG to revert to PSH via glutaredoxin. Next, we turn to immunity and inflammation. This is an example from the neuron system. And toll-like receptor 4 signals via MIDI88 and TLIF to activate NF-kappa B and AP1, turning on inflammation genes and NF-kappa B mediated cytokines. When GSH is low, these pathways fire more easily and switch off more slowly. So microglia stay primed and neuroinflammation becomes chronic. GSHC4, a salt-permeable GSH derivative, reduces phosphorylation of NF-kappa B P65 and its nuclear translocation. This is evidence that restoring intracellular GSH can blunt NF-kappa B signaling, and that this axis is pharmacologically targetable. In principle, the same upstream redox strategy we discussed earlier applies here as well. From inflammation to host defense, how GSH supports host defense against infection. We will start with bacteria. Left panel, NEM, a phytoreactive alkylator, causes sharp extracellular K+ spikes around 20 and 70 minutes. Adding DTT, a phytoreducing agent, brings the curve back down, showing a phyto-dependent reversible effect. Right panel, GSH DAX, GSX, bind the KEF-KTN gate and open the channel K+ out, H+ in, acidifying the cytoplasm and decreasing bacterial fitness. GSH can also stress bacteria in other ways by disturbing thioldisulfide and redox balance and drug sensitivity. Exogenous GSH at relatively high concentrations is bactericidal against multi-drug resistant Acinetobacter baumannii in vitro. More importantly, sub-inhibitory GSH plus meropenem restores killing of carbapenem-resistant isolates. This sensitization appears GSH-driven, suggesting GSH or pro-GSH compounds as a potential adjunct. While bacterial effects include direct pathogen targeting, viruses are different. GSH acts mainly through the host, restoring redox balance and disturbing disulfide-dependent viral maturation. It dampens NF-kappa B-driven inflammation, so the drive for viral replication weakens, and higher intracellular GSH also hinders entry, reverse transcription in retroviruses, and proper protein folding and assembly. Next, an example. Preclinical but clear. In aged flu-infected mice, GSH-C4 restored intracellular GSH and reduced viral load, evidence of host-directed antiviral effect. Human RCT. NAC, a GSH precursor, 600 milligrams twice daily for 6 months, reduced flu-like illness and improved cell-mediated immunity in older, high-risk adults. Infection often raises glycation pressure, and GSH helps control glycation. That's our next topic. Glycation landscape. Alpha dicarbonyls from glycolysis, especially methylglyoxal, non-enzymatically glycate proteins, forming advanced glycation end products, AGEs. The first-line defense against reactive dicarbonyls is the GSH-dependent glyoxylase system, shown in the green box. GLO1 and GLO2 detoxify methylglyoxal using GSH. And this is the key point. GSH is regenerated at the end of the cycle. Clinically, keeping GSH and redox balance up lowers dicarbonyl stress and limits downstream AGE formation. Oral GSH improved redox status and reduced oxidative damage in older adults with type 2 diabetes. It was associated with lower HbA1c, consistent with GSH repletion, reducing glycation stress and improving glycemic control. Think of GSH budget. Glyoxylase is GSH neutral. It uses GSH and gives it back. By contrast, GST conjugation, which we will look at next, spends GSH and doesn't give it back. With that in mind, let's move to detox. In short, this detox pathway runs on a shared currency, GSH. GST spends GSH 1-for-1 to make GS conjugates, and those conjugates are pumped out, so sustained GST conjugation depletes the cytosolic GSH pool, and mitochondria can't make GSH. They rely on import from the cytosol. That's our next topic. Mitochondria can't synthesize GSH. They must import it, forming a distinct mitochondrial pool, MGSH. Adequate MGSH limits mitochondrial ROS. When GST-driven detox drains the cytosolic pool and limits import, MGSH falls and cells become vulnerable, even if total GSH looks normal. MGSH sustains mitochondrial FAS biogenesis through the GSH-dependent protein GLX5. When MGSH or GLX5 is low, FAS delivery fails, the respiratory chain weakens, ROS rise, and labile, meaning redox active, iron accumulates. In dopamine neurons, dopamine in the presence of iron forms quinones, DAQ, that covalently damage FAS proteins and electron transport chain components, further increasing oxidative stress. The dopamine neuron example is important in Parkinson's disease, but I will skip the detail today. In this kind of iron-driven oxidative setting, glutathione status can become a key determinant of cell survival, and that idea is a key link to the cancer section. Now, in the final section, let's look at glutathione and cancer. This is the classic view of glutathione. Even normal mitochondrial respiration generates ROS, which can damage DNA and contribute to mutation. GSH scavenges these ROS and helps protect genomic integrity. So, in a prevention context, the simple intuition has been higher GSH is better. Supporting this classic view, there are experimental carcinogenesis data suggesting a protective role of GSH. On the left, in a skin carcinogenesis model, exogenous GSH reduced tumor progression. On the right, in an oral carcinogenesis model, exogenous GSH also suppressed tumor development during carcinogenesis. At this early stage of carcinogenesis, oxidative stress may be a driver of progression. Taken together, these findings suggest that raising GSH can look beneficial. However, once a tumor is established, the biology can flip. Clinically, we often see a paradox. Higher GSH in tumors is linked to chemotherapy resistance and worse outcomes. This figure explains a key idea, sometimes called NRF2 addiction. Oncogenic signaling increases mitochondrial and redox stress, raising ROS. To survive, tumor cells activate the NRF2 pathway, which turns on an antioxidant response. As a result, GSH synthesis and recycling are upregulated, and cancer cells maintain a strong redox buffer even under oxidative stress. Importantly, NRF2 activation can be seen even in precancerous lesion. But once tumors are established, it becomes much more prominent. It also becomes more functionally important. In other words, in established tumors, GSH can shift from protecting the host to supporting tumor cell survival. So the next question is, what are tumors trying to avoid by raising GSH? One key answer is phalloptosis, an iron-dependent form of cell death. Now let's look at the mechanism. Phalloptosis is an iron-dependent form of cell death driven by lipid peroxidation, and it is distinct from apoptosis. Many tumor cells rely on XCT to import cysteine, which is then converted to cysteine. Cysteine is a key substrate for GSH synthesis, and GSH is required to keep GPX4 active. GPX4 is the enzyme that repairs lipid peroxides in membranes and helps prevent lipid peroxidation from spreading. So, when the supply line is intact, tumor cells can buffer oxidative stress and reduce the risk of pheloptosis. Now, let's see direct evidence for the link between GSH depletion and pheloptosis vulnerability. This data comes from an important paper published in Cell in 2014. On the left, after treatment with erastine, an XCT inhibitor, reduced glutathione GSH drops sharply. So blocking cysteine import quickly decreases intracellular GSH. On the right, the author used PSOM, a classic reagent that depletes GSH. Here, RAS positive means the more tumor-like cells, and RAS negative means the less tumor-like control cells. As the PSO dose increases, growth is strongly inhibited, especially in the RAS positive cell lines. In contrast, the RAS negative lines are much less affected. So the message is clear. When GSH is depleted, tumor cells can become much more vulnerable, consistent with pheloptosis. So why does GSH depletion become so dangerous? The key reason is GPX4. In this diagram, lipid peroxidation starts with initiation, then spreads through propagation, and finally ends at termination. Pheloptosis happens when termination fails. The chain reaction cannot be stopped, and then system collapses. GPX4 is the enzyme responsible for this repair step. It can produce toxic lipid hydroperoxides, PLOH, into less reactive lipid alcohol, PLOH. And here is the most important point. It is not written in this figure, but GPX4 cannot work without GSH as an essential cofactor. So when GSH is depleted, GPX4 becomes functionally inactive. Lipid peroxidation speeds up, and the membrane eventually collapses. This is pheloptosis. So how can we apply this clinically, especially to treatment-resistant cancers? The most important clinical implication is how to target persistent cells, which often drive relapse. These cells survive chemotherapy and can be very difficult to eradicate. But the graph shows a surprising weakness. In these plots, the blue line is the parental cells, and the red line is the persistent cells. Parental cells are relatively resistant, but persistent cells lose viability sharply as the dose of GPX4 inhibitor, RSL3, increases. This reversal happens because persistent cells shift toward a mesenchymal state and become highly dependent on GPX4 for survival. This is good news. The cells that resist standard therapy may be especially vulnerable to pheloptosis induction. That's why the GSH-GPX4 axis is a rational target for preventing relapse. So how can we translate this pheloptosis concept into a treatment strategy? one answer is to target the tumor's dependence on GSH. Direct approach, broad system Xc-. This is the XCT transporter we discussed. Using, for example, elastin glass or sulfasalazine that reduces cysteine import, lowers GSH, and can sensitize tumors to phallopotosis. Indirect approach. Here, the target is the tumor microenvironment. We modulate GSH-linked redox and inflammatory pathways to weaken cancer cells and make them more susceptible to immune attack. Prodrug. GSH-activated prodrugs exploit tumor high GSH to deprotect and release the active drug inside cancer cells. So, does this mean we should never use glutathione in patients with cancer? The answer is it depends. So let me show you a couple of clinical examples. Here is the first example. In this clinical trial, IV glutathione was given with cisplatin. It reduces cisplatin-induced peripheral neuropathy, and importantly, the anti-tumor effect did not appear to be compromised. In fact, the cisplatin response rate was reported to be higher in the GSH group. In addition, there's another clinical data set in ovarian cancer. In a double-blind LCT, GSH was added to cisplatin. Toxicity was lower, and more patients completed all 6 cycles, 58% in the GSH group compared with 39% in the control group, with no clear loss of antitumor efficacy. So, when about our situation? First, we should ask a basic question. When do we want glutathione and why? In most situations, the goal is to support antioxidant defense in normal tissues. But if that is the goal, I believe there are better options than glutathione. Of course, vitamin C is also a strong option, but most of you already know it, so I will skip it today. In the next part, I will introduce 2 practical alternatives. To set the stage, let's start with a key paper. This study showed that CD8 positive T cells can use phallopotosis-related mechanism to kill cancer cells. This suggests that interferon gamma from T cells can suppress XCT. That means cysteine uptake decreases and glutathione synthesis in cancer cells is reduced. As a result, cancer cells become more sensitive to lipid peroxidation. So metabolic intervention and immune intervention can converge on phallopotosis. And this is exactly where ozone therapy may work well. Ozone can't activate NLF2, so the concern is that tumors might increase GSH and become more protected. However, if we consider the interferon gamma XCT axis, the picture changes. Ozone may promote interferon gamma signaling in vivo. Interferon gamma can suppress XCT, which limits cysteine import and reduces glutathione synthesis in cancer cells. So even if tumors try to adapt, they may not be able to sustain GSH when the supply line is restricted. On the other hand, normal tissues can still benefit from adaptive NLF2 responses. If this is correct, it suggests a selective effect. It may protect normal cells and at the same time push tumor cells toward GSH depletion and apoptosis. At the top is a quote from the low-dose ozone concept guideline. For cancer treatment, it recommends a low total ozone dose, 500 to 750 micrograms, 2 to 3 times per week. At the bottom is a quote from the ISCO3 guideline, the moderate declaration. Here, for oncology, it recommends a low-level range, roughly 10 to 20 micrograms per milliliter, with a total ozone dose of about 500 to 2,000 micrograms. Prior studies suggest that in systems with a strong antioxidant buffer, such as whole blood, we need a certain stimulus strength to induce interferon gamma. In practice, that often means an ozone concentration around 40 micrograms per milliliter. So my approach is to start at a low concentration and then increase gradually while monitoring the patient carefully. Here, I keep the total ozone dose within the low-level range, but I choose a relatively higher concentration. The aim is to support the interferon gamma XCD axis. Our second option is alpha lipoic acid. Alpha lipoic acid is well known as a central player in the antioxidant network, but it has been suggested to have direct antitumor activity. There are two key parts to this mechanism. First, many cancer cells suppress PDH as part of the Warburg effect. Alpha lipoic acid has been reported to inhibit PDK1 and reactivate PDH. This can send pyruvate into the TCS cycle and oxidate phosphorylation. When mitochondrial respiration increases ROS, allolysis, which can promote apoptosis. Second, activated PDH has been reported to bind KEAP1 and reduce its normal regulatory function. If KEAP1 is locked, NRF2 can be driven toward ubiquitination and proteasomal degradation, and the cancer cell may lose part of its antioxidant defense. So, through this dual mechanism, raising ROS and weakening NRF2 signaling, alpha lipoic acid has been applied in oncology. Here is a table summarizing practical dosing ranges reported in oncology protocols. For IV infusion, doses are typically in the 300 to 600 milligram range. For oral use, reported ranges go up to 1,800 milligrams per day, often split into 2 or 3 doses. Let me briefly summarize the cancer part. First, glutathione is context-dependent. For example, in supportive care, GSH may help prevent cisplatin neuropathy. Some early models suggest a protective effect, but that does not mean GSH is a safe strategy. In established tumors, tumor cells may use GSH for survival and drug resistance. Second, this is why apoptosis matters. Many cancers rely on the XCT, GSH, GPX4 axis, and when GSH is depleted, GPX4 fails and lipid peroxidation runs out of control. Third, if the goal is to support normal tissues, we do not have to rely on GSH itself. In this talk, I focused on ozone therapy and alpha-lipoic acid. Glutathione is not a silver bullet, nor just an antioxidant. It's a multi-level file system. Understanding these axes allows us to choose more precise and safer intervention. Thank you for your attention.
Thank you very much, Doctor. The plaque of appreciation is for sharing your knowledge and expertise on our PSOM annual conference here in One Esplanade, Manila, Philippines, today, February 20th, 2026. Thank you so much, Doctor.